Hello, my name is Ravi Vij. I'm from My Cancer Haven. And today in the Conversation with Cancer Expert series, I have Dr. Ariel Grajales, a rising star in multiple myeloma at one of the leading cancer centers, Moffitt Cancer Center. And we're going to talk about a new class of drugs, which is getting a lot of press these days, Celmods, moving beyond the image. So welcome, Ariel.
Thank you. Thank you so much for having me.
So, Ariel, can you just lay the ground by telling us what are cell mods?
Well, I always like to start by saying that Celmods, it's although it's a new story, it's not that new altogether because everything started with the Imids back in the day, right? That we started with thalidomide, kind of a serendipitous kind of finding, which we ended up bringing into the myeloma space and finding good activity from it, right? Without truly understanding why. Then lenalidomide and pomalidomide came into the market, still with not a clear understanding of what the pathway, the mechanism of action was. And then it was around 2010 when this finding of the cereblon pathway and the protein degradation was started to be understood. And Celmods, and nowadays we have three currently under investigation, iberdomide, mezigdomide, and cemsidomide, are basically novel protein degraders that bring these ligase and target proteins into proximity, right? To begin this protein degradation through the UPS, the ubiquitin proteasome system. And that leads to this increase in apoptosis and decrease in cell proliferation altogether and the death of myeloma cells altogether.
So you mentioned there are three in development. Let's start with the first one, iberdomide. So what have we learned? What are the trials to date that we are aware of?
So iberdomide it was essentially was the first CELMA to be studied altogether, right? And it was at the beginning used as a single agent or just in combination with dexamethasone. And this is essentially what this pivotal trial essentially looked at, right? Population with relapsed refractory myeloma, patients that had essentially received um, therapies with proteasome inhibitors with such as like I mentioned earlier, lenalidomide and pomalidomide. They were essentially all of them were they were imid refractory, but also they were exposed and refractory in the vast majority of the patients to bortezomib and carfilzomib. These patients also they were refractory to daratumumab as well, right? And so it was a very interesting approach in different cohorts, and obviously it has a dose escalation and a dose expansion phase for these individuals with heavily pretreated myeloma, because although it included patients with more than two prior lines of therapies, the vast majority had more than that.
So I guess we'll review some of the data sets that exist. So as far as the drug goes in combination with steroids, I believe is where it was first studied.
That is correct. That is correct. And as you can see here, it just highlights what I mentioned a minute ago, right? Patients with very heavily pretreated disease with a median prior lines of therapies of six, right? So here we're talking about individuals that statistically speaking are running out of gas, right? But they have seen the three major classes, triple class refractory for the most part, PIs, IMiDs, and CD38, which we have to acknowledge that CD38 monoclonal antibody a decade ago essentially changed the landscape of myeloma altogether. So whenever we have these individuals that fail the CD38 strategies, those are ones that are not necessarily going to fare well altogether. So having options like this, iberdomide, is extremely encouraging. And in this trial, they also included patients with high risk disease, right? About a third of the patients had high risk cytogenetics, which historically we include translocation 414, 1416, and 17p deletion, right?
So I guess this was initially a phase one study. So we start out with how the toxicity profile. So how is the drug tolerated?
All these Imids and CD30 and Celmods, excuse me, had a very comparable toxicity altogether because mainly they're driven by the hematological toxicities that we can encounter. These hematological toxicities include neutropenias, thrombocytopenias, anemias, and obviously the patient can have an increased risk of infections as a result, right? In these initial clinical trials, infections and mainly upper respiratory tract infections, including COVID-19, played a role for these patients. GI toxicities, such as diarrhea and constipation, also were prevalent in this population. And we have to also account the historical rash, right, that we've seen with patients on IMIDs, such as LEN and POM, was also encountered here. But for the most part, the grade 3 and grade 4 toxicity that we always have to be mindful of is cytopenias and infections.
So how effective was this regimen?
But quite frankly, it was for this type of population, it was quite respectable, right? Because when you see an overall response rate of 26% in patients that essentially had no other options other than obviously we're excluding these patients that nowadays we consider for novel therapies such as bispecific antibodies and CAR T-cell therapies. Having these type of responses with a progression-free survival of around 13 months was not bad at all, right? These numbers were pretty decent for this heavily pretreated and difficult to treat population that are in desperate need of a good treatment options for them. And we have to see what happens not only with this single agent activity, but also the combination strategies that we're also going to be talking in a minute, right? But I think given the fact of this mechanism of action, right, that essentially enhances T cell activities and NK cell activity and proliferation, we can not only consider iberdomide and mezigdomide in the future as a single entity, right? Because we have to consider also what their impact is going to be when we combine with these novel strategies that I just mentioned, bispecifics and CAR T, right? Which are T cell dependent therapies. So this is a very interesting topic of discussion. Like I think is Dr. Loinel that says that these Celmods are cappuccinos. Well, we can call them also Red Bulls, right? Because they just essentially give them a little bit more of an enhanced activity altogether.
So the other one is obviously mezigdomide, and this was also studied in phase one, phase two trial along with dexamethasone. So what was this population like?
So this population, once again, was very heavily treated, right? Here we're talking about a median prevalence of therapies of 6. These individuals had also high risk cytogenetics in more than a third of the patients, but they also include patients with plasmacytomas, right? And they were all of them triple class refractory, right? So once again, we're talking about the population that have seen everything and the good strategies altogether. And like I mentioned earlier, patients that have failed CD38 monoclonal antibody strategies typically do not fare well. And so they included these individuals in desperate need of therapies.
And how was this tolerated?
Interestingly enough, it was a little better tolerated than iberdomide in terms of the deep hematological toxicities, right? You can see that definitely there is still grade 3, grade 4 events in terms of anemias, thrombocytopenias, and neutropenias in this cohort of people. But in general, they had a very comparable toxicity, although a little bit better tolerated, I would say. The diarrhea and the constipation that come with the GI toxicity was not as pronounced altogether, but fatigue remained obviously a recurrent event for these patients, although fatigue is one of those side effects that I am not a big fan of because it's really difficult to quantify. And there are so many things that can contribute to the fatigue altogether, but these are side effects that definitely presented. But there have not been any new safety signals for these products, so it seems that it's going to be very, very well tolerated for our typically frail population.
And what can you tell us about the effectiveness?
Once again, really good numbers altogether for this difficult to treat population. The overall response rate hovered around the 30-50%, depending on the cohort that you're looking at. But the progression-free survival was around 4.4 months, and the duration of response was around a little over 7 months. So these are numbers that typically we do not expect for patients in this clinical scenario. So very encouraging.
And the latest one that has started producing some data is cemsidomide, and this too has been studied in phase 1, 2 in combination with Dex. The population, where anything to point out there?
Yeah, so cemsidomide is kind of the new kid on the block for this class of drugs. In this trial, they also included patients with more than three prior lines of therapies with lenalidomide, either an IMiD, PI, and CD38, and they were typically patients that had relapsed refractory myeloma once again with late relapses. Median line of therapies was 6. They included in this population patients with prior BCMA targeted therapies, right? In the form either of a T-cell engager or a CAR T. So these are kind of the real world individuals that we're going to start seeing now, right? Because nowadays with the approval of 4 bispecific antibodies, well, 3 that target BCMA, and also 2 CAR T products, both in the second and third line setting. Most of our patients will be in this clinical scenario of being not only triple class refractory, but also BCMA refractory as well, or at least exposed. And they included also in this study a very difficult to treat population that sometimes can be underestimated, which is extramedullary disease, right? Because individuals do not do well typically, and their responses are not as exciting typically. So, but obviously, this is early. We have to let the data mature and to see what the real activity of cemsidomide will be for these patients. But it's very encouraging. The toxicity profile is very comparable to what we've seen with the others, although it seems that it's even better tolerated than mezigdomide. The hematological toxicities are still prevalent, including some grade 3, grade 4, and infections, mainly upper respiratory tract infections, are kind of what we typically see for these guys.
How active is it?
The numbers look really, really good, right? Very similar to what we saw with mezigdomide earlier on. We see overall response rate hovering around the 20-30%. So for this type of population, these are kind of unprecedented numbers, because you can see individuals here that have failed BCMA targeted therapies. So these are the guys that typically, once you fail all these strategies, we are not, the world is no longer our oyster in terms of treatment decisions, right? So to see these type of results, it's extremely encouraging, and we're even seeing to some extent deep responses with PRs, very good partial responses, and in some occasion even complete responses, right? So it's not common to see this type of outcomes in this very late relapses disease.
So it seems like now we've obviously, like with most of our drugs, and at least the conventional agents, gone into triplets. And uh, as far as iberdomide goes, I understand a number of these combinations with daratumumab, bortezomib have been studied, especially. So is there any specific thing that you wish to comment on in terms of how they've been tolerated?
Absolutely. So, I think the combination strategies in myeloma have been extremely, extremely important because we know that the single agent activity for most of these products they're not necessarily as great as we want, right? So these synergistic events that we create with the triplets and quads in the earlier line setting, of course, are pivotal, right? They're very, very important for our patients. And we know exactly what to expect in terms of the toxicities from each individual products, right? We know the hematological toxicities. We know of the predominance of blood clots from Imids. We know of the peripheral neuropathy that can come from bortezomib. And so it was not unexpected to see this type of toxicities in these different combinations. In this trial, there was a combination of Iberdex with Dara, with bortezomib, or with carfilzomib. We can see that the thrombotic events were not there, right? For these events, peripheral neuropathy obviously was predominantly seen in the group of the bortezomib arm. The GI toxicities were prevalent. The hematological toxicities were also seen, but it does not seem to be a cumulative effect, and for sure there were no new safety signals for these combination strategies, right? So these are more of combinations that we're familiar with.
And so, honing down into the three-drug regimen of iberdomide with daratumumab and dex, uh, because this, I think, as we'll discuss, has been the regimen that has moved forward to pivotal studies to get the drug approved. What have we seen in terms of the response rates here?
Now, here we see that these numbers are once again extremely impressive. Here we're seeing an overall response rate of 45.9% with deep responses. More than half of the patients had a clinical benefit when using this combination. And here, once again, we're talking about a heavily pretreated population with median prior lines of therapies of four, right? So we need to see how this data matures altogether. But this cohort E is extremely impressive and extremely encouraging because, as you can see, these patients were refractory to Imids, PIs, and CD38s in a good proportion. So having this type of numbers with an overall response rate of almost half of the patients, it's actually very impressive altogether. But we need to see how this data matures a little longer.
So I guess we now are moving into these phase three studies as well with some of these. I guess we're now seeing some preliminary reports of activity and success. So the Excalibur relapsed refractory myeloma study. What can you tell us about this?
So Excalibur was basically a phase three trial that is looking at this combination of Iberdex with Dara compared to the standard of care Dara Velcade Dex. It seems that this combination is extremely positive and potent. Once again, we need to see how this data mature, but we're talking about patients here that have received at least two parallels of therapy, 1 to 2 parallels of therapies. I'm sorry, and that are essentially exposed, have not been exposed to Velcade or no, they're refractory, but not they have been refractory but exposed to bortezomib and CD38 monoclonal antibodies. So we have to see how this data matures altogether, but it's definitely a good combination, especially just because of the synergistic potential that they have in terms of NK cell activation, right? So we'll have to see.
Another area I guess that iberdomide is heading into is as maintenance therapy.
Absolutely, and this is actually a pretty exciting trial. We're fortunate enough right now to have that study ongoing at Moffitt as well. So basically it's looking at the combinations, the potential role of iberdomide as maintenance, right? Because we know that lenalidomide has been the pillar of maintenance in patients with multiple myeloma. We know that these indefinite strategies with lenalidomide have been kind of the standard of care for many years because len has been probably the best studied drug in this setting, right? So seeing iberdomide in the context of maintenance for these patients makes a lot of sense. But once again, in myeloma, we have a good problem to have, which is that patients are having such a long lifespan and their responses are being so long lasting that it's going to take time for these data to mature. So more to come, of course, but very encouraging.
So then switching gears back to mezigdomide, that too has moved into three-drug regimens. And what can you tell us about the experience to date with a three-drug regimen of mezigdomide?
Absolutely. So yeah, just similar with what we just mentioned about iberdomide, mezigdomide seems to have really good activity in combination strategies. They started looking at combination with mezigdomide and bortezomib, and also mezigdomide with carfilzomib for these patients. So that was cohort D and cohort C that when they moved into the phase two expansion. These patients, once again, they were, in the earlier setting, right? The median prior lines of therapies one was 1 to 2, but for the most part, they were exposed to proteasome inhibitors. And they included patients with high risk cytogenetics. They had patients that with had prior CD38 monoclonal antibody, prior refractoriness to Imids. So we're talking about patients that once again have seen good drugs, have failed them, and now need something different to tackle myeloma. But pretty much expected from what we would hope in this clinical setting for sure.
So what have we seen in terms of effectiveness here?
These results have been amazing, right? With a median progression-free survival on the bortezomib cohort of 17.5 months and 13.5 for the carfilzomib combination. So these are numbers that, quite frankly, look very encouraging. We have to see how that translates into potentially an overall survival benefit as well. But when you look at all the prior strategies that we've had, right? When you do the combination with Dara Pomdex, Isa Pomdex, Dara Kdex, Isa Kdex, those numbers are not too far from this, right? If you remember Apollo, for instance, Apollo was around a 12 months progression-free survival. So when we're seeing these kind of combination results, it's very, very encouraging altogether.
So I understand these are also now the basis of pivotal studies
Mhm.
with, I guess in this case, it's called the successor studies with mezigdomide bortezomib combination and also mezigdomide carfilzomib combination. So, to summarize, uh, where do you see these drugs heading in the future? You mentioned obviously that we are seeing great results in the combinations, but you also mentioned about their potential to be combined with bispecifics given in sequence with CAR Ts. So, how do you see the field evolving?
And that's a great question because in reality, um, the combination strategies have been phenomenal, right? But ultimately, nowadays we're talking about functional cures in the case of patients dying with myeloma and not from myeloma, but I don't think it's enough, right? I think our patients deserve better, and all these novel strategies for sure can pave the way for that. These cell mods have the potential of improving these novel therapies, not only before but even after, because if we think about the biology of these cell modes and how they enhance the T cell activity, how they decrease the T cell exhaustion, maybe this is the key to potentially make the current drugs that we have even better, right? So in the CAR T and bispecific setting, this could be a very good strategies, and there are trials looking at that already. And I hope for our patients that we will have more and more options. Hopefully, iberdomide and mezigdomide will be approved in the upcoming years, sooner rather than later. So I think it's a bright future for them, and it's another great option for our patients, and in a very well tolerated manner. So we're actually very, very happy to see these options come to the table in the near future.
Well, I really wish to thank you very much for taking the time to educate the audience about this, and hopefully we can turn to you again in the near future to tell us more about these studies as they read out.
Absolutely. I would be more than happy to. And thanks again for the invitation.